This animation presents the InterStim full implant procedure. The full implant procedure involves implantation of a tined lead and neurostimulator following a successful PNE trial procedure. Position the patient on the table and administer sedation. Prep for sterile surgery by swabbing the lower back, sacral region, and buttocks with an antiseptic. Drape the patient to allow for observation of the pelvic floor and great toe motor responses. Ensure a clear view over the buttock and perineal area. After the proximal end of the white patient cable is handed off the sterile field, attach the ground pad to the patient's heel. Connect the red pin of the long screener cable to the ground pad and the black pin to the white patient cable. Finally, plug the adapter end of the long screener cable into the test stimulator. After verifying the settings, turn the test stimulator on and verify that the status light is blinking. To identify landmarks using AP fluoroscopy, first mark the midline. Using the sacroiliac joints as a guide, locate and mark the sciatic notches. Draw a line connecting the notches. The S3 foramen is located about 2 centimeters lateral to the crosshair formed by the midline and the sciatic notches. The foramen needle skin entry point will be located about 2 centimeters cephalad of the S3 foramen to accommodate a 60-degree angle insertion. Inject a local anesthetic to numb the skin near the entry point of the foramen needle. S3 is the target foramen. The foramen needle skin entry point will be located 2 centimeters cephalad of the S3 foramen. The needle should be placed at approximately a 60-degree angle relative to the skin and should always be oriented in a cephalocaudal direction. The needle tip should be inserted to a depth just below the anterior surface of the bone. To confirm ideal placement, connect the white patient cable to the non-insulated portion of the foramen needle and turn the A dial on. Slowly dial up the amplitude on the test stimulator. Observe for motor and sensory responses. The desired S3 motor response in the pelvic floor is a bellows, a pulling inward or deepening of the intergluteal fold. The desired foot response for S3 is a plantar flexion of the great toe and occasionally other toes. For women, the S3 sensory response is often vaginal sensation extending to the perineum and rectum. In men, the common S3 sensory response is sensation in the rectum extending to the scrotum. To insert the lead introducer, first remove the foramen needle stylet and replace it with the directional guide. Then, gently remove the foramen needle, being careful to stabilize the directional guide so it is not removed. Make a small skin incision at the exit site of the directional guide. Using live fluoroscopy, place the lead introducer sheath and dilator over the directional guide and advance into the foramen. Twist the hub of the dilator to unlock it from the introducer sheath. Remove the directional guide and dilator, leaving the introducer sheath in place. The tined lead has 4 electrodes, numbered 0, 1, 2, and 3. 0 is the deepest, most distal electrode. Insert the tined lead into the introducer sheath and advance the lead to the proper depth. To confirm the ideal lead placement, ensure all 4 electrodes are distal to the introducer sheath and test for response. Once appropriate responses are obtained, the tines can be deployed. To deploy the tines, hold the lead in place and carefully withdraw the introducer sheath. The tines will deploy as the sheath is removed. The lead stylet is removed along with the introducer sheath. Test all 4 electrodes again to confirm previous responses after deployment. Obtain final lateral and AP images. Identify where the neurostimulator will be placed and inject local anesthetic at the skin and surrounding tissue. The pocket site should be located below the iliac crest and lateral to the edge of the sacrum. Make an incision just large enough to accommodate the implanted components. Create a pocket using blunt dissection and electrocautery. It should be no deeper than 1 inch for the 3058 InterStim 2 INS to ensure proper telemetry with the physician programmer. To avoid infection, it is recommended that the neurostimulator implant site be irrigated with antibiotic solution in sterile water. Do not use saline. Using the tunneling tool loaded with the passing straw, tunnel from the lead incision to the pocket incision, taking care to avoid damage to the lead. Make sure the tunneler passes through the fat and is not too superficial. Unscrew the tip and remove the tunneling tool, leaving the straw in place. Carefully pass the lead through the straw until it emerges at the pocket site. Remove the straw at the pocket site. Dry the contact points on the lead and insert the lead into the header of the neurostimulator, making certain the blue tip is inserted as far as possible. Use the torque wrench to tighten the set screw on the header until you hear a click. If the lead cannot be advanced, use the torque wrench to back the set screw out slightly. Do not remove the set screw. After confirming proper fit, insert the neurostimulator into the pocket with the etched side facing outward, away from the muscle. Irrigate with antibiotic solution in sterile water. Do not use saline. With the neurostimulator in the pocket, use the physician programmer to check impedance and verify that all InterStim system components are correctly connected and tightened. Assure hemostasis and close the pocket with subcutaneous and skin closure, taking care to leave no dead spaces. Secure the incision and exit site with dressing. Use the clinician programmer to program the neurostimulator and document the settings. Provide the patient information on post-op care, follow-up guidelines, and instructions on how to use their handheld patient programmer.